Well, I think we can classify having a blocked nose based on two broad categories. One is where there's a structural deformity, so the hard bits of your nose, if you like, are out of place, causing a blockage, or that the lining itself has become swollen and is causing a blockage. Of course, occasionally there are more sinister causes for the nose being blocked. And really, it's my job as a clinician to try to get to the bottom of what it is. And in the history, so that's when we ask you questions, your doctor, whether it's me or someone else will ask you how, when did it start? Often patients will say, well, it was absolutely fine until I played rugby 2 years ago, and then I can't breathe through my nose. And now clearly that's, to anyone, it is going to be obvious what's happened there. And then sometimes patients find it's seasonal. And seasonal blocked nose or seasonal rhinitis can often be due to what's commonly known as hay fever. And actually, hay fever is really grass pollen allergy. It's not always grass pollen. It can be other seasonal allergens that increase, particularly in the spring and summer. And that causes a blockage of the lining. And often symptoms with blocked nose can be associated with other conditions. Often the sinuses are involved at the same time. Because remember, the nasal lining and the sinus lining is all one and the same. In fact, the lung lining and the nose and sinus lining is one and the same. It's often called one airway because patients often find that when the nose is inflamed, often the lungs trigger off and vice versa. And making one better can help the other. And that's in a particular type of rhinitis. So there are multiple causes of blocked nose which we can think about. Beyond structural problems and the lining being inflamed, there can be dynamic problems with the nose. You may have known of a very famous footballer called Robbie Fowler back in the 90s, who used to wear these little strips across the nose. And the reason why he did that was these little cartilages, the alar cartilages, when he breathes in, cause a negative pressure. And in some people where this cartilage is a little thin, it can suck in. Now, we know that flow through a tube is dictated by its narrowest point. So your nose can be as wide as the Channel Tunnel, but if it's narrow just here, then the flow is going to be dictated by that. And little changes in that flow, there's an equation, those that are good at physics, called Poiseuille's law, where flow is proportional to radius to the power of 4. So that means that you make a little change in the narrowness here, whether it be a bit more or a bit less, and it makes a huge impact to flow. So often people have things called alar collapse, where this cartilage falls in when they breathe in, which can cause a dynamic problem with their breathing. Anyway, I think I'm wittering on about nasal obstruction, which I could do for ages because it's very interesting, but I'm open to further questioning. Well, beyond our history, examination is crucial. So by seeing an ENT surgeon, myself or anybody else with an interest in this, one can find out where the cause of the nasal obstruction is. So usually we would examine the nose by the means of initially anterior rhinoscopy. Now that's a word for looking at the nose from the front, often with the headlights. I often joke with my kids that I'm the only type of doctor that really looks like a proper cartoon doctor, because traditionally we used to wear mirrored headlights here that we could look into and look up the nose, deflect the light and go and look up your nose. And from the front of the nose, we can see that initial bit of the nose, the anterior nasal valve. We can see if there's collapse. Often we see that patients have lots of crusting at the front of the nose. And this comes into another, you wouldn't think there's so much physics up the nose, but sometimes we see that, patients that have turbulent airflow, because the nose isn't quite straight, their airflow it's not laminar, it's turbulent, letting crusts deposit in the front of the nose, and that causes localized infection and crusting and blockage. So we look for those signs. But then the crucial part of a nasal examination with an ENT surgeon is something called a nase endoscopy, a fiber optic nase endoscopy, where we pass a tiny little camera up the nose. It's a little tickly, it's not terribly uncomfortable, but we examine the nasal lining. We see if the septum, that's the midline cartilage, is straight. We see if the turbinates, those are sausage-like outpouchings on the sides of the nose that increase the surface area, are engorged. We look at the lining to see if there's any polyps. And then we pass the nase endoscope all the way to the back of the nose and back and forth to examine the different parts of the nose, to one, make sure there's no very rare tumours, which can occur but very unlikely. And we also look at the back of the nose to make sure there are no enlarged adenoids, which can happen in younger patients, and ensure that there's no other unusual findings. And that gives us a picture of what's happening in the nose. And once you have a good diagnosis, we can work out a management plan. Of course, depending on the outcome of the diagnosis, but primarily nasal inflammation or rhinitis, there is no cure. And I think that's a fundamental part of the management of rhinitis, the patient understanding it's a chronic condition. And the process of treatment is about lowering the inflammatory response there is in the nose. And there are different strategies in that regard. There's allergy avoidance, it's an allergic type issue, and often we can send off blood tests or do skin prick tests to find out what the allergen is. Sometimes just lifestyle changes like, house dust mite allergy and washing your pillows and sheets at a particular temperature can make all the difference. And then, of course, there's further intervention maybe to dampen the immune response with nasal steroids. And sometimes antihistamines, either topical or oral, are necessary. And occasionally patients with lung problems associated with it need to see a respiratory physician or other medication that we can both start together. And so that's the sort of medical category, the inflammatory type nose. And then there comes the some surgical, truly surgical category, if you like, but often the inflamed nose that causes, that is treated medically in the first instance, can have a surgical element to their management plan, I should say. And that can be to treating the turbinates, those sausage-like outpurchins I'm talking about. Or when the lining gets so inflamed it becomes polypoidal, i.e. nasal polyps causing obstruction, those can need surgical intervention. Unfortunately, the truth of the matter is that this condition is not curable as we know it. Down the line, there are immunomodulatory drugs that are currently way too expensive for normal use that may be a light at the end of the tunnel, but at the moment they're not particularly accessible, they're very expensive. So that's the sort of the inflammatory side of things. And then we have the structural issues, and primarily that's septal deviation. Often patients will have had trauma to the nose or it's grown that way, but the cartilage in the midline of the nose has become wonky and is obstructing the nose. Patients will often come to me with, for example, a deviation to the septum to the right, just to have more blockage on the left. And you can get this paradoxical engorgement or hypertrophy of the inferior turbinate on the other side, those sausages that we keep mentioning, that can give you blockage on the opposite side of the deviation. And those are the kinds of patients that often do need surgical attention. There's as many sprays you like. If your septum is very bent, it will need surgical remedy if we want to breathe better. And I think that the takeaway point is that it seems like a fairly trivial thing, all the things that are going on in the world that could happen to our body. But actually, when it comes to quality of life, unblocking someone's nose can make all the difference. Whether it be snoring and not be able to sleep next to your partner, being able to sort of have a dry mouth all day and night, to sounding pretty nasal, which I'm currently doing. Having a blocked nose can be very troublesome. So I don't think we should under egg it. Another thing I haven't mentioned is that there are certain conditions which one may presume is because of a blocked nose, but actually isn't. And the thing that I'm thinking of is the loss of sense of smell. So often patients will come to me thinking, oh, I can't smell, I must have a blocked nose. But actually, it's not always the case. It's not always obstructive anosmia, as we call it. It could be that there's a problem with the nerves at the top of your nose, often seen in COVID, where there's a loss of sense of smell or a change in sense of smell. And I've done another talk on that on Top Doctors, which you can have a look at.
Very good.